Direct primary care is an innovative alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Conception, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
Direct primary care is a model that allows patients to pay their physicians directly for care that is provided. This allows physicians to regain control over their practice and their lives and allows patients the ability to choose the type of primary care they wish to receive. I am Dr. Rachel Dirksen of Remedy Internal Medicine, and this is my DPC story.
Dr. Rachel Dirksen was born and raised in rural Charlotte, Iowa. She graduated with honors from Loras College in Dubuque, Iowa, with majors in both biochemistry and English literature. She spent a year in Madison, Wisconsin, volunteering in AmeriCorps VISTA before starting medical school. She received her medical degree from the University of Iowa Carver College of Medicine and is a member of the Alpha Omega Alpha Honor Medical Society, as well as the Gold Humanism Honor Society. Dr. Dirksen completed her internal medicine training at the University of Colorado Health Sciences Center in 2012, where her training emphasized primary care. After residency, she worked as a clinical assistant professor for the University of Iowa, where she enjoyed teaching medical students and residents, as well as caring for patients in the outpatient setting. After leaving her clinical position at the University of Iowa, she enjoyed volunteering at the Iowa City Free Medical Clinic and working toward the creation of Remedy Internal Medicine. She opened Remedy Internal Medicine in September of 2021 and is loving spending time with her patients and her family. She is board certified by the American Board of Internal Medicine and is a member of the American College of Physicians. Welcome to the podcast. Thank you so much for tuning in. Find out more about DPC, including resources, discounts, my favorite tools, books, and tech at mydpcstory.com. The mapper has been updated. I am so excited to keep repeating that because now you can look for practices on this podcast who have shared by specialty. Follow us on your social media platforms at mydpcstory and be sure to subscribe to our newsletter and, of course, the podcast feed so you won't miss when the next episode drops. So with that, I am so excited to chat with Dr. Dirksen. I met her just a few weeks ago, and you can tell from her opening statement, paying for what services you get. Amazing. No third party involved. And I want to open with the fact that you grew up in rural Iowa. Like I was Googling and it said town population in 2024 of 390. I was thinking like Marg Helgenberger situation in Nebraska, but no, that is rural. And so I want to ask about what was life like in terms of how you accessed medical care, especially. And was it that you needed care and you just got it? Or did you have barriers like we do now when you were growing up?
Yeah, good question. I grew up on an acreage actually outside of Charlotte. And so in the heart of farm country, I mean, it's a beautiful area, but it is an area that everybody knows you. And they know your parents and your grandparents. And so it's a highly relational area. We did have primary care, but we had to drive for it, right? So when I was very little growing up in Clinton was about half an hour away that we would drive for our primary care. And then eventually there was primary care in DeWitt, which was about 15 minutes drive away. And certainly specialty care was a little bit harder to access. We very much you did not necessarily go to the doctor for any little thing, right? Like so it was, you had to have a pretty significant concern to go in. But I think for that reason, I didn't always think about going into medicine just because I just didn't have a lot of medical providers who were known to me, I suppose. And so when I started thinking about medicine, it took me a while to come around to it.
And tell me more about that, because as I've shared on the podcast, my experience in Superior, Nebraska is very much for generations, people have only known the town physicians and the non-physician providers. And so it's interesting to hear that, one, you had to drive because a lot of people did not grow up rural. And two, that going to the doctor meant like you really had to go to the doctor. So can you tell us about like when you did go, did you feel like they knew you? Did you feel that they had an understanding of not only medical issues and how to diagnose and treat them, but also what resources you had available in your community to pull from if you needed a referral?
Yeah, I think I remember going basically because it was kind of a job for all of us to go. So when I was little, my mom brought all four of us kids to the doctor together because otherwise it was just like so much to be bringing kids back and forth to things. And so I almost always remember being little, like with the whole crew of us there and getting our vaccines and all of those things. And so, and it was always somebody we had known for a while and had a relationship with, which was really like helpful. And I think that my parents certainly trusted them, but it just made it that you may do a lot, I think, when you had some things happen. And so you didn't always reach out to physicians, which thank goodness, frankly, that we didn't have any like significant chronic disease states. But I think about that a lot now for people who still live in that area about what it means to have chronic disease and how to access care, especially specialty care, and how they have to travel for that.
You grew up in rural America and then you spent time volunteering with AmeriCorps in
Mhm.
a totally different part of the world. So, how did you end up with one, choosing to go with AmeriCorps, and two, how did you end up in Wisconsin?
Yeah, I started looking at options for what I was going to do. So I should say I went into college thinking I was going to be a dentist. And so I applied for dental school. They had like an early acceptance program for that. And I knew I liked science and I liked working with people. So I thought, well, that'll be a good fit. And then realized that my spatial ability is not what it should be, perhaps, for dentistry. And so I realized that I had to start thinking about other options. I didn't think that I was like decided that wasn't for me. And so I thought about research, but that is, you just don't get to talk to people as much with research. And then people were really pressing me to think about medicine. And it just felt really hard and long. And I wasn't sure about it. I actually tried to apply for PA school, and I had an English professor who declined writing a letter of recommendation for me because she said I should go to medical school. And so I thought that was really fascinating, but I was like, okay, fine, I guess I will do this. And so applied for medical school. And at that time, you could only take the test sort of at certain times of year. And so I had this year to find something to do after college. And I had done a service learning honors thesis in my undergraduate college at Loras and really enjoyed that and was looking at how I could volunteer or do something to help others for that year in between. And my husband was going to graduate school in Madison, Wisconsin at the time. And so I was looking in that area, and they just happened to have an interesting VISTA position that was at a college, and you would help students get set up with service positions throughout the community. And so it was more of an indirect service. And that was a really interesting experience because I learned you can be very idealistic and want to help people, but until you have skills, there's not a lot that's going to be done with maybe idealism. And so, yeah, it was eye-opening in that way that I think you can work for nonprofits, and I think they do a lot of good work, but we also need to make sure that we are helping people in the way that they need and helping them with the skills that we can offer. So that was an interesting experience in that way.
Amazing. I'm doing the listeners a favor by putting myself on mute. I literally was laughing so hard and very loud when you were talking about the spatial differences between a dentist and a physician, because absolutely, when I was going to post-bac, I was with dental or pre-dental students while I was pre-med. And I was like, please just give me a calculus problem because I literally can't do this stuff. But also the other thought I had was, when you're talking about like you could have lots of things, but if it's not the things that the person needs, that's not helpful. And we can translate that in so many circumstances because, especially like I think about when the hurricane hit the mountains of Western North Carolina, Dr. Gonzalez and Dr. Kelly had shared there's bottles of water, but there's no ways to get the bottles of water to the communities who need them. And that's a terrible example of what people are still suffering through. But the idea that there's people always who are wanting to help out there in our country, especially, but if you have the right network, if you have the right support, it's a very different way of keeping the care locally determined, whether that be in school in education or medical care, whatever it is. And I really love that you've mentioned this, especially talking in regards to your story and where you are practicing. It's an hour outside of Iowa City about, and you've chosen to go to a community that doesn't necessarily have billboards and Super Bowl ads for the healthcare systems where you're living now. And so I really think that that is awesome. And I want to ask there, when you were in your year at VISTA and you were noticing these, I guess, mismatches between what is needed and what we have to fill those needs, where you were in Madison, as you were going forward in your medical career after you decided to be a physician, how did your experience in AmeriCorps VISTA impact the way you think about medicine today?
Yeah. One experience in particular comes to mind because one thing that I don't know if people realize about AmeriCorps Vista is that you live at the poverty level. And so for me, it was about $9,000 for that year that I was in Madison. And that you do have insurance, but the insurance doesn't cover everything. And so it was like my first time being an adult and going to the doctor. And so I went to the doctor, had this acute issue, got it treated, and then like 3 months later got a bill for $600. And I just started crying and I didn't know what to do. So I called my dad, and he had kind of worked through insurance things in the past. And so he was like, well, you can call and you can make a payment plan and you can do all these. So I did that. I like called, I made a payment plan. I could only pay like $50 a month or something like that at the time. And so that just stuck with me so much that I was like, but I have insurance. I don't understand. Like, this is so hard. And I just didn't really understand how insurance worked or how to navigate it. And I just realized how challenging it can be for people when you just don't understand this insurance system. And when they don't tell you up front how much it's going to cost, that's really challenging.
This is super ironic because I literally just gave a talk about Medicare and open enrollment and Medigap plans and Part D and the changes in 2025 to the assisted living yesterday down the hill. And it's pervasive, this idea that insurance is healthcare. And it's amazing that you had a resource like your dad to help in this situation, but it's so sad when a lot of people do not. And especially as we see bills going up and up and up, and people choosing to not pay certain bills like food and electricity so that they can pay for their medicine, especially in cases where medicine's actually really dirt cheap and you don't need to be paying $2,000 deductible for a medicine that costs 2 cents. And I want to mention here the book Never Pay the First Bill by Marshall Allen. I'll have that linked in your blog and on our list of books, but definitely a very powerful resource for anybody who is wanting to know more about what actually is healthcare and how does insurance impact our delivery of healthcare in this nation. And also the organization, the nonprofit dollar4.org. Dollar4 is an organization where you can literally upload your medical bill or your patients especially, they can upload their medical bill, and there's a whole team of people who can help you or your patients figure out, is this something that one, you should have been charged for, and help you understand the medical bill and options after that. So definitely two resources that I thought of as you shared your story. And I can just imagine though, just knowing that your income is $9,600 of that is expected to go towards one visit. Why would you want to go to the doctor the next time around?
I
Oh my
know.
goodness. So now how did you end up then in Colorado
Yeah.
after Madison?
Yes, I knew. So as I was going through medical school, I loved this primary care experience. Like I loved the growing old with your patients. I loved the undifferentiated disease that walks into the door and you get to have the diagnostic challenge. Like I really enjoyed that, but I didn't want to have as broad a scope as family medicine. I was nervous about sick kids, honestly. And I was also nervous about the OB aspect of things. And so internal medicine sort of drew me in. And I did an elective my fourth year in medical school called the continuity of care elective in internal medicine, where I got to be with an internist throughout the year, just seeing patients with her, which was really great. And so as I was looking around at internal medicine residencies, I specifically looked at ones that had primary care tracks. And so the University of Colorado has a grant through the state of Colorado where they get funding for extra residents so that internists in residency have less inpatient time so that they can have some protected time for outpatient rotations. And so I really loved that about Colorado. They also had 4 different hospital systems that we worked through. So the University Hospital, the VA, the Denver Health, the public hospital, and then also a private hospital. So it was a way to experience 4 different systems. And so that called to me as well. It was a great experience, honestly, to be able to see the differences in the different systems and also how people navigated that with insurance, because at the time, only residents of, this was before the Affordable Care Act, so but only residents of Denver County could go to Denver Health, the public hospital, but the University of Colorado was in Arapahoe County, which is outside of Denver County. And so those patients, if they were discharged, they were not always able to go to the University of Colorado, but they were also not able to go to the public hospital. So it felt like you were sending them off into the abyss, and that felt very strange. And so I began to really feel like the system was not working for my patients, that this insurance system was not helping people get care. And it made me feel really uncomfortable to discharge sick people to nowhere. It just felt very bad.
You had thoughts about what happens after they get the taxi waiver and then they go off into the abyss. Yeah, it's so heartbreaking. And I know that there are listeners out there who are absolutely shaking their heads. And even after the Affordable Care Act, to think about, there's totally discrimination in emergency rooms, especially like I remember where we trained, we would get people who were not supposed to have been discharged from the emergency room they presented at because they were with a particular insurance or lack of insurance, they were dumped at our hospital. And I mean, dumped. Like, it is so sad, some of the things that we saw. And in the time of a person's greatest need, when they're really feeling like they have an emergency and or they have nowhere to go. So I think that's so impactful to hear that that was one of the, molding things that you saw while along your medical journey. Let me ask you there, because when you talk about a primary care focused residency, I love that you had that continuity of care experience shadowing with one internist, because that is really cool to think about the different things that that doctor saw and you saw with them. What were the patients like? Were they in that clinic in particular, even before you got to residency, were they in a relationship with that doctor? And what were any frustrations that you might have heard while in that continuity rotation?
Yeah, it was really great because even I got to see patients more than once, which is, I think, the struggle in training is that people, they don't realize that when you have this relationship with patients over time, it becomes much easier to take care of those patients. And I think so often medical students and residents just see like, oh, everybody's new to me, everybody's really hard, I can't handle all of these things. But when you get to know someone so well, that's valuable. And the physician that I shadowed was just phenomenal. And she had a great relationship with her patients and a good relationship with her staff. And her nurse had been with her. And I thought, oh, good. This is, a great team approach to taking care of patients. And I look forward to doing this. And I think in residency, it's so hard because you're right. You're just going on all these different rotations and you do have your continuity clinic. And I did get to really develop relationships with some great patients in residency. And so that helped with that, but that's what like helped me get through the medical ICU like rotations, right? Like I was like, okay, I could get through this because I get to go, I think I recall a patient, I diagnosed her endometrial cancer in residency and she brought me flowers. Like those are the things that you're just like, this is what I want to do. Like this is what I wanted, how I want to take care of people. And not that the inpatient experience wasn't good. It was just not the relationship building, I think, that we get in primary care.
Totally hear you. Let me ask, was the residency program that you were in opposed or unopposed?
What does that mean, Mariel?
No worries. So, great point of clarification. Opposed meaning, were there other residencies in the hospital vying for the same patient population, or were you guys the only residency in the facilities you guys rotated in, especially
Oh,
with,
interesting. Okay.
yeah.
Yeah. Yeah. So at the university, so in the different hospital systems, so the University of Colorado, the family medicine residents would share some patients with us. So they would often take the patients that came in from their clinic, would go to the family medicine, and then from our clinic would come to the internal medicine floor. And there was some, there's a little bit of triage happening there. And then at the private hospital, there was prelim residents who would rotate through with us. But at the VA and the public hospital, there were not other residents that would vie for patients.
Gotcha. And yeah, for a lot of us who are through residency, it's not necessarily pertinent, but definitely for those people who are in medical school and who are listening, it can sometimes be a difference as to, how easy it is for you to have patients who need a shave biopsy. And do you get to perform it, or does the dermatologist resident get to perform it? So definitely something to think about, opposed versus unopposed, while you're in interviews for residency. When it comes to when I asked earlier about how AmeriCorps VISTA helped carve out how you thought about medicine, you talk about the love of relationship-based medicine. And I want to ask about how your experience in Colorado, especially finding that or confirming that you really loved the relationships that you had with patients, how did that translate to you moving back to Iowa and your next job after residency?
Yeah, I mean, we very much enjoyed our time in Colorado, but Iowa is our home. And my husband's also from Iowa, and he thought we were a little bit crazy moving back. But our families are around here, and that was important to us. And so I did look around at various options, and there was like a private practice that I interviewed with. And then I thought that I would really enjoy the teaching in the academic setting. And so I did come back to the University of Iowa. And that was and still is an important part for me, is the teaching and mentoring for medical students and residents. And so that, I think, was a big draw for me. I realize now how much I really enjoy mentoring, which I think has evolved over the years. I don't think I recognized that always at first. But yeah, those relationships were important to me. And then I sort of feel like the people of Iowa are my family, and I'm taking care of them. And so it was meant a lot to me to come back here and do that. And so that was a big part of the draw here.
It's fantastic. And, I think that it's so fitting that you do find yourself loving mentorship, just especially because you had such a good internist as a mentor, because I think that that really impacts how we view primary care and how we view any specialty, is if we've had somebody who we can see ourselves in, who we can see as a person who we admire their skills in terms of people skills, way that they, use their medical knowledge and apply to patients, bedside manner, those types of things. I think that's so cool. And let me ask you now, when it came to your experience at the University of Iowa, was there a change in how you were able to practice, I should say? Like, were you able to maintain the relationships that you wanted to going into that position, comparing when you started to when you left?
I think because I was there for 8 years, and I would say I certainly got to know my patients well, but it sort of got to the point, and I think we all feel this in fee for medicine, that I was starting to get to the point where, RVUs were talked about and my production time. And I also got to the point where, we were overbooking patients, and I was booked out for months, and my panel was full, and I just kept feeling like I was working so hard, and I was just never enough. I just felt like I was apologizing for all of these things I had no control over. Patients would be like, I can never get a hold of you. I can never get in to see you. I've had these 3 things happened, and I had to go to urgent care, quick care, all these different things. And I just felt like this was just not how I imagined my practice to be. And I think the biggest issue was just the loss of control over that. And then, of course, your family life suffers as a result of that too, right? So I just remember once I had a sick kid, and I called off, and I had a full clinic, and they were like, well, are you going to come in on a Saturday to make up that? Otherwise, those patients are going to have to be booked out 4 months. And I was just like, what? Like, how is this okay? This is not going to work. And so I just started to get to the point where I was like getting worn out and I was just not feeling the joy of what we do as much. And so I knew it was time to start looking around at other options. And it was my husband actually had seen this article about DPC. I think it was from Dr. Gunther, like Julie Gunther. And I read it and was like, oh, this is really great. And then my friend was like, oh, Anna, who was my senior resident in Colorado when I was an intern, is doing this in Little Rock, Arkansas. And I was like, no, I did not know that. That's amazing. And so I reached out to her and she was like, Rachel, like I was going to leave medicine and I love it again. Like you have to think about it. And I was like, okay, I'm going to think about this. This is something I'm going to do, And so that was really the turning point for me that I was like, other people are doing this. It's not crazy. I'm young. I don't want to do fee for medicine for 25 more years. I'm not cut out for that. And I think it's worthwhile to do this thing that people seem to love, that patients seem to love, and that seems to be a great option to get away from the headaches that are insurance-driven medicine.
And especially how you said, you had a sick kid, and we're still going to even bring up the fact that your patients have to be rescheduled to 4 months out. Like,
Yeah.
Do you feel good? I feel like that's like Asian mom guilt. Like that's just, I say Asian mom, not PC maybe, but that's because like I totally get the passive aggressive stuff from my family growing up. I'm like, yeah, thanks. Thanks. I feel that all the way. So let me ask you there, because before opening your DPC, you also volunteered at the Iowa City Free Medical Clinic. So was that a bridge between the university and your DPC, or did you work at the medical clinic while you were at the University of Iowa?
Yeah, so I did not work at the Free Medical Clinic while I was at the University of Iowa. I left. Of course, we were booked out a year. So I resigned in June of 2019 for July of 2020, which was quite the year, right? And so I had a 2-year, 50-mile non-compete clause. And so I had planned to take a good year off. And we had sort of been saving up money for that situation. And then I knew that I would still want to do something with medicine. So I reached out to the Iowa City Free Medical Clinic and was said, hey, I have this year that I know I am not supposed to be paid for my practice of medicine in the area, but I would really like to continue to practice medicine. And it was challenging because that was COVID and they had little space for people. And so they said that Tuesdays, like I think it was Tuesday mornings, that I could come in and do some volunteering there. And so I did that. And then my daughter started virtual kindergarten that year. And so I helped with her virtual kindergarten, and then we started working on the opening of Remedy. And so it was honestly a crazy year, right? Because the pandemic was crazy. And then this horrible thing called the derecho happened in Iowa that year too. And so it was just a lot, but it was great experience at the Free Medical Clinic. The people and the staff there are so dedicated. And I think it was just, really hard going through COVID on everybody, but on them in particular. And what I liked about the Free Medical Clinic is just, again, undifferentiated disease, like seeing these really unique situations, how wonderful people, because most of the people there were volunteering, right? So like just people sharing their time. But again, the downside being that it's hard to create relationships in these populations, and you don't have that. I mean, I think some people do get sort of recurring patient population there, but I think it was challenging in that situation.
And you had mentioned also that the choice to go to the free medical clinic was also impacted by this non-compete. So was that it in terms of like you were able to find a place that you were not getting paid for, or were there any other issues with the non-compete and you being able to practice and be paid for practicing again?
Right. So I opened up my practice 14 months after I left the university. And so the day I opened, I got a letter that I was in violation of my non-compete. And so I did reach out to my lawyer at that time and responded to them, and they sent a letter saying that if I wanted to continue practicing, I should pay them $140,000 roughly. And so I was, of course, totally overwhelmed in that situation, and I'm scared. And I talked to my lawyer, who is lovely, right? And obviously, I think we all know that non-competes can be challenging legally, like in terms of like how valid they are. But I think when you're faced with a huge entity coming at you with these things and you're just this little person who's trying to open a clinic, it feels completely overwhelming to be in that situation. Thankfully, we negotiated that down and I bought out the rest of my non-compete. So I think that was like $50,000 of my savings that I had to pay for that. Although my husband and I argue it was probably worth that much for my happiness. But I think that it's very frustrating to me that non-competes are still a part of our physician professional situations, and that in this era where we're having physician shortages and where people can't get in to see physicians, that there are people who may want to practice and then that they cannot. And I think you could argue, yes, I could have driven 50 miles, but at that point I had a 5-year-old and a 3-year-old. And I loved my community. I didn't want to leave this community. And so it was just a very frustrating experience to have to go through that, especially as I was just about to open, right, like my doors and start my happy new practice. So it was a lot to manage.
I can't imagine. We take it for granted sometimes that we're in a state where it's not enforceable to have a non-compete, unless caveat is if you're with Kaiser. But it just breaks my heart to hear that, because it's like I can picture you just free spirit, so excited to craft your clinic the way that you needed to, and then this letter happens. And so I wonder though, like, was somebody keeping tabs? Like, that is so creepy that the day that you were, the
Yeah.
opening time
Yeah.
is when you get this letter.
Yeah. Yeah. I mean, I had stayed as an adjunct at the university. And so I was still teaching and doing some things there. And I think people were aware that I was like moving towards this direction. So it was not necessarily a secret, but I think they felt compelled to come after me to enforce this, which I suppose they universally want to do. But I just think that it just removes any leverage that physicians have when they're trying to argue for better conditions for themselves and their patients. And I just don't think that that helps anybody.
Absolutely. And when you and your lawyer were talking, let me ask first here, is your lawyer, or I don't know if it's the same lawyer that you have now, but was this a small business attorney, or what type of attorney did you work with?
She's an employment lawyer and she has worked in a number of different cases, and she's actually a friend of mine. And so that was helpful too, because she was able to calm me down and reassure me that things were going to be okay. And frankly, that's one of the things that I want to make sure people hear is that, yes, that you can go through these situations and go through non-compete clauses. And at the end of the day, like, it's going to be okay. Like it's some money, but you'll get through it and you can keep practicing. And I wouldn't stay one day in a job you're not happy at if it means that you just have to negotiate these things out.
And like you said, your ability to have yourself back and not be sitting on this pile of stress is priceless. So let me ask you there, when you and your lawyer were talking about this letter and how to deal with it, were there takeaways that you found so helpful in terms of the things that you mentioned that she had to quote unquote calm you down with, that were concrete, like things to focus on amongst the chaos of this non-compete and the university going after you, basically?
Yeah. Basically, she was like, this is a conversation. You know what I mean? This is a negotiation. And that's the way that we address this. This is not a personal attack. This is just something that we need to work through. So she was very helpful in talking me through that. And then we kind of worked through, and it felt like a house negotiation, weirdly, like just going back and forth, trying to figure out what would be agreeable to both parties. And so it was frustrating and stressful, but I was thankful that she was reassuring to me that we would get through this and it would be okay.
I picture, to a university, 140,000, whatever, like we get that, admitting half of a student into our, one of our university classes. But, for a doctor who has, I think there was one doctor who said on the podcast that they were living on bologna sandwiches throughout residency. And like, it's not as bad as $9,000 at the poverty level, but like when you're making, usually, like, especially the years you and I graduated, around $45 to $50,000 a year and you have two kids and a spouse, that's a lot. Like 50,000, even though you got it down to that, that's a lot. And so I just think about, what kind of people there are on the university side of these situations who stand by non-competes. Because there's definitely been examples where people have been able to talk to the people enforcing the non-competes and get them down to, getting out of the non-competes. And so I'm wondering, in terms of your guys' negotiations, your conversation, BS, I'm sorry, that's so irritating that literally it is a conversation for people when it's not emotional, when it's not their money that they're having to lose. Were there any pieces of strategy that you guys talked about, either from the verbiage in the contract or the way that you guys reacted and were able to come to the table and discuss it, that you think about when you talk to other people about, look at your contracts, look at the non-competes, think about where you're going to practice in the future and if this could impact you?
Yeah. And I thought of that at coming into it, because at least in the University of Iowa system, every physician is required to sign the same non-compete. It's non-negotiable that if you want to work there, that's what you sign. And so that was interesting to me because, if I had heard from people, like try to negotiate going in and it was just like, no, like this a non-starter, like either yes or no, you work here or you don't. And so that I think is challenging. I do think that there are a number of places that you could consider negotiating non-compete situations ahead of time. And I know there are some places that they'd rather have you work than leave, right, and not work. And so I think, having these conversations about what you can do to adjust that, I just think that in this situation, it was not in their, they're just not interested in doing that.
Because you did, negotiate, had the conversation, and you paid the $50,000,
Mm-hmm.
you were able to continue with Remedy. And I want to ask now, because you have come through this, what type of impact you're making because now you are a DPC physician.
Yeah, I think there's impact in multiple ways. I think it was in some ways exciting for other physicians to see that I'm succeeding, right? Like that I left and that I'm doing okay and I can do this. And I still have a good relationship with the university in terms of my patients seeing them. I sort of think of them business separate from the physicians who were my colleagues and who I enjoy interacting with. And I still, am an adjunct and help take students into the DPC clinic, right, and show them this experience. And so I think that in that way I'm having some impact. And then also just being able to show patients a different type of medicine that they've experienced has been really fun. I think people are surprised, right? Like how wonderful it is to have somebody to sit down with them for an hour and talk through their health, or to really sit down and put the puzzle pieces together and solve something that's been a mystery, or to just have you available to go through the difficult times. I think that is just so valuable. And I don't think we recognize how much time that takes, and the time that you spend even outside of the clinic visit with patients, just trying to coordinate care and take care of them and make it a good experience with specialists and for our patients with specialists. I think that's so valuable as well. And I hope that other people see that this is a good way, like a good experience in primary care. And so we encourage people who are in medicine to do this. I hope for so long, and I for sure in internal medicine, that people have maybe looked down on primary care. But I have this hope that if they see how happy we are and how wonderful it can be to take care of patients in this way, that more people will consider taking it as their career.
Amazing. And just before we started recording, I was asking you for recommendations near Ames because I have a patient who may be moving there. And that's what we get excited to be able to do. Like, I would not have, I think, been as emotionally invested or cared as much if somebody asked me, like, yeah, I'm moving to Idaho because of the pandemic. Do you know anyone out there? I'm like, I don't know. I'm too busy. I got to go to I got to do my charts. Like, I don't have time to look up people in Idaho. So I think that's so cool. Literally, you're getting to just be a doctor. And absolutely, I'm totally with you even going back to your mentorship. Like, this is a way of mentoring people. You sharing your story on this podcast is a way for people to see themselves reflected in fellow physicians who we find similar stories listening to people, because there's so many stories on this podcast itself, so many other resources out there as of today compared to when you and I opened DPC practices, that there's ways to. I mean, thankfully you had your senior resident Anna in Little Rock who'd open her own, but it's like there's so many ways to find your way into DPC, and you can't ignore that everybody who comes into this movement can share the stark differences between fee for service and DPC. And what you will take away from that is what you will take away. But for those people who are looking for a different way, DPC is definitely one of those ways. So, with me mentioning how I spoke to a group at the assisted living, I want to ask about your area in terms of demographics. Like, do you have at your clinic, because you're internal medicine, do you have more of a Medicare beneficiary type of population? Do you have a mix of younger and older? Tell us about your demographics.
Yeah, I was looking at this, and my youngest is 21, my oldest is 98, and my median age, I know, is 64. And so that I would say that sort of Medicare, I do probably skew more Medicare population. And so what I think is fascinating about that is, like, financially, that doesn't necessarily make that much sense for patients. They just care about having someone to talk to them. And I do think that in the era of corporate medicine, that navigating the system is so challenging, that these smaller clinics like ours can be really attractive to people who are the older population as well. Like, just being able to, have a friendly voice that they know, answer the phone, or connect with them, or talk to them on a weekend if they need something. And I think that is so valuable. But it is funny because I thought I would get more of the, like, high deductible, like, play. I don't know. I thought I'd have more, like, people who were interested for, like, some of the financial benefit. We do get some of those. And I have, like, a handful of uninsured patients, a handful of Medicaid patients, but I would say I more often have, like, Medicare.
And, with my population definitely swinging very heavily towards Medicare beneficiary population, I see it. I see the same thing, though, that like these people also experienced, like, hey, I could just call up my doctor when I was a kid and, oh, I can do that now again. Like, they totally love that relationship. And that has been the main factor as to why people join at our DPC who are of Medicare beneficiary age. So that's amazing. Let me ask you this, because of where you grew up, are you offering services via telemedicine for those people who want the care at your clinic and from you directly, but who cannot necessarily get there as easily in person?
Yeah, so we do offer telemedicine services. I have a couple people who drive, or who sometimes drive, or we do telemedicine as far as like 2 hours away. Oddly enough, I would say that more people just want to see me in person, which I also think maybe is because we skew towards the older population. But yes, we do offer some telemedicine options.
And for the younger people, like the 20s and 30s, that end of the population spectrum at your practice, what have you heard from them as the reason that they're joining?
Yeah, some of them have chronic conditions. And so that just the availability of somebody to answer their questions is really helpful. And then I have some who, for example, one has maybe a high health anxiety and has a high deductible plan. And so even going to, like, an urgent care or quick care is like $400 for him. And so giving him value for that, like, he can kind of check in with me if something comes up, but doesn't necessarily have to pay those high prices for given that he's on the high deductible plan. And so I do have, like, a couple of people who are like that and really value that.
Amazing. So let me ask you, because you were once there in terms of a person who was not yet a DPC physician, when you were talking with Anna, as you were, reading the article that Julie Gunther had written, I would love if you can pull from that time, but also just what you hear now from other people who see you as the DPC doctor. What are some of the things that you hear from people in medicine about, oh, why I can't do DPC, right?
Yeah, it's interesting because I do think that some people judge us, right? As well, you're charging people to see them. And I think we've gotten so far away from the money that we just don't realize that what we were doing before in fee-for-service was definitely charging people money. We just were so divorced from it. We didn't have any control over it. And I started to see that more in the last few years of my fee-for-service time, because people would be like, can you code it this way? Can we make sure that we don't talk about this? Or can we, this got billed and I got a big bill for it. Can we make sure we code it differently? And so I would feel horrible, when people would get these big bills. And so I would started to get like nervous about how I was billing things and uncomfortable. And so I think that in this way, at least there's more price transparency, right? Like I can tell patients like how much things cost. We do have like the cash-based labs that I can tell them that's how much these prices are. And so I think there's so much value in that. And so it is interesting when people feel that way, that, oh, well, you're charging people money. It's like, you're charging people money too. We just don't know. You just don't always see that. I probably, like, financially, it probably is maybe in some ways more lucrative in the fee-for-service world, but I feel like my happiness is much higher. So that's totally worth it to me. And it's not a huge financial loss to me to do DPC. I think it's actually been pretty equivalent.
Well, incredible. So that is a wrap for today's episode. We will be talking more with Dr. Dirksen about 3 years. She's already passed her 3-year anniversary in DPC, and how she achieved a wait list within 2 years of DPC practice. So it's incredible to hear the rest of her story. Join us over on our Patreon community. Thank you so much, Dr. Dirksen, for joining us today.
Thank you.
Thank you for joining us for another episode of My DPC Story, highlighting the physician experience in the world of direct primary care. I hope you found today's conversation insightful and inspiring. If you want to dive deeper into the direct primary care movement, consider joining our My DPC Story Patreon community. Here, you'll have access to exclusive content, including more interview topics and much more. Don't forget to subscribe to My DPC Story on your podcast feed and follow us on social media as well. If you're able, I'd greatly appreciate if you could leave us a review. It helps others to find the podcast. Until next time, stay informed, stay healthy, and keep advocating for DPC. Read more about DPC news on the daily at dpcnews.com. Until next week, this is Marielle Conception.